Bienvenue, buenas vindas, bienvenidos. Welcome you all. Thank you for joining this webinar. As you join, and we give time for others to join the session, I will ask you to please introduce yourselves in the chat. You can add your name, organization, any institution you're working with, and the country you're coming from. We will start very soon, within a minute, just so that we have a quorum to kick off the session. Welcome, welcome. Thank you for joining us. Perfect. Thank you for adding your details in the chat. You're very welcome. Hello, Rita. Hello, Anna. Thank you for joining us. So as we reach the first starting minute of the session, again, a good day and welcome to the 14th Key Population Community of Practice webinar. This webinar will be focusing on prioritizing and programming for HIV prevention for key populations in GC8. I'm Clarissa Pinto from WHO, and it is a pleasure to be here with you today and sharing this session. So thank you for joining us, and we hope that you can engage as much as possible with us. Next slide, please. Again, as you join, put in your information in the chat. Let's get to know each other. Just a reminder that there is simultaneous interpretation available in English, French, Portuguese, and Spanish. So you can choose your preferred language using the interpretation option in Zoom, just down below your screen, your Zoom window. We will have a time for discussions, and for this specific time for discussions, if you want to voice your question, you can just raise your hand and let us know. And please do place your questions in the Q&A. We will leave and focus the chat for comments or links and anything that you want to include as a comment to presenters and participants. Next slide. So just to kick us off with some thoughts, and just to say that we are meeting at a very difficult and different, changing time, affecting how we plan our programs, how we implement services, and these changes are affecting key population programs when difficult prioritization decisions are made. Even where incidence is declining, key populations are historically left behind, and prevention coverage remains very low. So we need to consider these changes and this situation, so that for this session, we bring great speakers and panelists that will help us reflect on what is needed to make it work. Next slide. So I'll just give you an overall of today's session objectives. So we are going to be sharing evidence to support prioritization of key population programming in GC8. We will deepen understanding of the key tools for KP prevention services. And we'll be learning from government and community networks to strengthen advocacy and effective prioritization. Next. And we are off to a good start, as it's my pleasure to introduce you Maria Villan, Senior Technical Advisor for Key Populations at the Global Fund. She will present some clarifications and tips that need to be considered to prioritize key populations in the GC8 application. Maria, over to you.
Thank you so much, Clarice, and hello, everybody, and thanks for being here today for this important discussion. My name's Maria Phelan. I work in the Community Rights and Gender Department at the Global Fund as a Senior Technical Advisor on Key Populations, and we can go to the next slide. So I think first, to frame this discussion, it's important to frame all of the discussion within the strategic shifts that are taking place under grant cycle 8. I won't read the slide completely, but what I will say is sustainability, transition, self-reliance, integration, and strong community health systems, as well as optimizing domestic resources and co-financing, are all key in this grant cycle and will be part of all of the thinking around investments under this grant cycle. There's a very intentional focus on increasing and accelerating sustainability of HIV responses, including for key populations. And this path may be challenging in relation to key populations, but it's an important one that we're going to walk together. So we can consider that as we walk through this discussion. Next slide, please. Just a bit of brief information on the process. There's a lot more information on our website in relation to this, but I just wanted to highlight a couple of things. There are some changes in relation to the process. The first being that for focused portfolios, there's a more streamlined application process with a smaller number of annexes to fill out. And countries need to submit funding requests for all eligible components at the same time for colleagues. At the same time, so for HIV colleagues, this will mean liaising closely with those working on the other diseases, as well as health system strengthening. What will be really important during this process is for KP representatives, including those in CCMs, but all others, to plan in advance to identify shared priorities for all groups and to ensure that everyone knows them and is aware. Having those communities consistently repeat the same messages and making sure that there's alignment there will increase the chance of inclusion within the funding request. So timely and inclusive communication cannot be understated. It's also important to recognize that there's compressed timelines for 2026, a lot happening in a very reduced amount of time, which may be challenging. So as I mentioned, quick and timely communication will be really important. Next slide, please. Also to mention that there is a couple of adjustments to the funding request process. There's the classic process, that's number 2, that looks similar to, or the same really as the previous processes in terms of the timeline and in terms of the steps. There is also, and it's important to be aware, a grant-ready process. This is a new process where there is a shorter number of steps in the timeline. So if CCMs nominate existing PRs, they can request this process as a part of the moving forward. And what it means is it expedites the grant negotiation and reduces the work. But what it also means is that things like the detailed budget and performance framework will be submitted with the funding request. What that means is there'll be less time for engagement later in the process. So it will be important to engage early and to ensure that priorities are clearly identified within that. Next slide, please. So just a short moment on the modular framework. The interventions to support key populations are similar to previous years, with the key interventions sitting in the HIV prevention module. What's important to recognize is we have streamlined the modular framework. It was quite a long document in the past. And now under HIV prevention, rather than by each key population for interventions such as condoms, we have combined the interventions for condoms for key populations, for AGYW, for other vulnerable populations. That doesn't mean that specific and tailored program can't happen. It could, it can, and it should for different populations, but it's just a way to better categorize the interventions in the modular framework. Important also to highlight that community system strengthening has been added under the RSSH module. So important interventions such as community-led monitoring, capacity building for community-based or led organizations can be found in this module. I think it's also important to mention that interventions to reduce human rights related barriers or gender related vulnerabilities and barriers to HIV, TB and malaria are now also under RSSH. They can be integrated within disease response programming for HIV, for example, for key populations, and they should be, but they can also be added as cross-cutting interventions across all 3 diseases. And so this gives a bit more opportunity for intersectionality, as well as both targeted and integrated responses in these areas. Next slide, please. So moving on to the priorities for grant cycle 8 for key population programs. Really, as we move into this space, and as there are overall in many contexts reduced resources for HIV prevention for key populations, it will be important to consider 3 strategies of optimization, adaptation, and integration in order to ensure and continue coverage of essential services for key populations. It will still be important to prioritize service delivery based on epidemiology, based on HIV incidence, and based on the resource availability. And we would continue to advise to design programs for key populations based on a trusted access platform approach. Really where this is about building from a place of trust with key populations and combining multiple service delivery models to ensure access across various platforms. Having said that, there may be an opportunity to rethink what have been underutilized service delivery approaches, for example, virtual approaches, work in pharmacies to keep a continuation of essential coverage. As mentioned as well, it will be important to consider optimization and adaptation of existing strategies from a sustainability lens, as well as ensuring continued coverage. So this might mean a careful review of performance of particular parts of the program to make sure that they're fit for purpose, or maybe there's opportunities to optimize within them. Assessing the cost effectiveness of certain strategies and informing what should be retained, what can be adapted, what could be integrated, and what could be optimized. Where possible, although we'll talk about this a little bit more in a moment, supporting the integration of programs for key populations into primary healthcare, but it will require a thoughtful process, the identification of risks in advance, and making appropriate strategies to address them. And we can move to the next slide. So to discuss this in a bit more detail, what's important within this discussion, I think, when it comes to integration of HIV services for key populations, is we know key populations access services across the HIV care continuum through a variety of different approaches, both differentiated service delivery as well as health-based service approaches and community-based. And we know that services should be provided with quality in a context of trust, confidentiality, respect, and anonymity for key, vulnerable, and most at-risk populations. When considering an integrated approach, it will be important to think in advance carefully about any risks that may be there, and to come up with strategies to address those. For example, rapid and unplanned transition can lead to a reduction of access to certain services for key populations. So adopting a gradual approach over several years based on community-informed or led assessments for readiness will be really important, or strengthening and supporting links between community settings and KP competent health services. When that shift happens to health facilities, there may be a decline in availability of services provided by community-based organisations, leading to a decline in access. So consultations with community, with key populations to guide the efforts to streamline those services will be important. Protecting
1 minute warning.
Thanks, Clarice. I'm on my last slide. Protecting community service delivery points will be critical in some cases, and making the most, as I mentioned, of opportunities offered by other approaches such as virtual interventions, KP competent community pharmacies might be a possibility. It will be important to think about specialized services, and if it's appropriate to integrate those services, for example, needle and syringe programs for people who inject drugs, which are very specialized services which require a specialized approach. It shouldn't be integration in all cases at all times. If community delivery approaches need to be preserved, then this should really be pushed for, and assessing, alongside assessing the capacities of health service staff to identify gaps in services and other mitigation strategies. And of course, stigma and discrimination reduction remains critical, developing those training and mentoring plans, integrating mechanisms to address rights violations in health services, for example, or addressing those barriers through other interventions. And so these are just some illustrative ideas of some of the mitigations that could be put in place. Now, I think that's my last slide. Maybe we could go. We will share these afterwards, but just a list of tools, community guides developed by community partners, which I believe will be quite useful to you all in terms of engaging in the process. Some are not yet online, in which case the email addresses are there that you can reach out to get copies of those. And of course, I'm available to answer questions in the Q&A and throughout. Thanks, Clarice. Back to you.
Thank you so much, Maria. Very clear and helpful information to help countries and communities through this process, interpreting the updates to the information for this application year, and also the new categorization and need for considerations for key populations. So a quick reminder for participants to please use the Q&A for questions for Maria. We will be tackling those questions through the Q&A. So now we move from evidence to application. And it is a pleasure to have our next speaker, Clemens Benedict, as a senior advisor for HIV prevention at UNAIDS. He'll be sharing a set of relevant global tools for decision support, so you can use them and choose what to protect, what to adapt, and what to integrate, and to make those choices transparent and participatory. Clemens, over to you.
Thanks so much, Clarice. And I'll be speaking to guidance and tools primarily for prevention, but of course, with a person-centered approach, they apply to HIV and some related health issues collectively. So next slide. We actually start with the overall guidance document. If you can go on the next slide. The consolidated guidelines on HIV, viral hepatitis, STI prevention, diagnosis, treatment, and care for key populations. And as you see from this title, actually this brings together what used to be 5 detailed guidelines for the different populations. And actually it goes beyond prevention, it goes beyond HIV to cover viral hepatitis and STIs as well. You see here the theory of change, of course, with the ultimate goal in terms of HIV, STI, and hepatitis outcomes, but then prevention, diagnosis, and treatment targets being the next step, and then the access through the different interventions, which we'll look at in a bit more detail in just a moment. Next slide. So in terms of prioritization, this guideline, which is of course based on a comprehensive review of evidence, has basically 3 essentials there for impact on HIV and the other disease outcomes. The first one are the enabling interventions addressing structural barriers to health services for key populations. The second one are the specific HIV and other disease interventions, so diagnosis, prevention, treatment, and care. The broader health services related to that, such as mental health or sexual reproductive health services, and then supportive management type and demand side interventions. Next slide. The approach of consolidating all those guidelines then implied that some specific highlights for populations were summarized in much shorter policy briefs, which are still available for the 5 key populations, and you see them represented here. If we go to the next slide, we actually have a high-level summary of all the content and how the different intervention areas apply to different key populations in terms of this normative guidance. And of course, this is a mix of different interventions that should build on existing system, that should have complementary co-financing from other sources. So it's not proposed that all of these interventions should go into Global Fund proposals. There's, of course, need to prioritize and link this to what is already available in terms of enabling interventions, the health and HIV interventions, and then the broader service and supportive environment. Next slide. So maybe a few highlights on new guidance. There's actually new guidance specifically in the space of harm reduction, opioid agonist maintenance treatment, and needle and syringe programs for people who inject drugs. And you have links here to detailed webinars on those, but maybe just a few words on each of them. If you go to the next slide. So for OAMT, the WHO recommends OAMT for most patients with opioid dependence. So it's really the primary treatment for opioid dependence, with the strongest evidence for a range of health and social outcomes, including HIV, with evidence of about a 50% reduction through OAMT. The sustainability is, of course, therefore particularly important. What is not recommended is, of course, involuntary and unplanned interruption of OAMT, and also interventions like rapid withdrawal. When unplanned interruptions occur, and that's, of course, particularly important when we talk about continuity of grants, there's, of course, need for contingency measures because there's potential negative serious consequences of such disruptions. Maybe the big question, of course, is we have low coverage of OAMT. Global AIDS monitoring showing about the median of about 10% in countries against the 50% target. So how can we do this in a context of declining funds? There's 3 or 4 key things that actually could happen to still achieve and progress towards targets in OAMT. We have huge variation in unit cost, even for the basic commodities. Methadone should be cheap, less than $100 per year, certainly, and considerably lower, possibly. We still see much higher prices in some country programs. There's opportunities for simplifying service delivery, take-home options, and really 90% of the benefits of OAMT, we have used that in some modeling analyses, are actually non-HIV benefits. So there is wider social and health outcomes, improved, of course, health outcomes for other conditions, but also social outcomes, reduced crime, and by reallocating just a small proportion of resources from punitive approaches, just looking at, for example, the large costs of imprisonment, to this preventative approach could actually finance the achievement of the OAM target. So just a strong case for co-financing, which most middle-income countries at least could achieve and thereby achieve the targets. Next slide, going to the needle and syringe guidance. There's also a number of updates here. So a new guidance page describing basically in 5 models what's really needed for implementation, from the assessment, the population sizes, the implementation models, comprehensive service approaches. Of course, this should be part of a harm reduction program, the monitoring, including community-led monitoring, scaling up with very practical, examples on how to calculate the needles needed based on different uses and frequency of use informations. Of course, average here 300 syringes per person annually. That's a departure from the earlier slightly lower benchmark. And of course, peer-led NSBs are particularly effective, and that's still one access platform to use, and we get to access platforms in a moment. Of course, also technical information on options like low-dat space syringes also included in this guidance document. Next slide. Now, WHO has issued for the clinical elements some prioritization guidance here, with 1 tier that is essential, including like PMTCT, PEP, blood safety, harm reduction services, in particular where programs are already implemented because disruptions can be so harmful, and provision of condoms and lubricants here in the first tier as well. And then, of course, depending on the population, interventions like PrEP are in the important category, but could be in the tier 1 in certain epidemiological settings with very high HIV incidence. And all of this is actually covered in additional prioritization guidance and in the prevention needs estimates that you may also have seen presented in earlier webinars. Next slide. Now, the GPC Resource Hub has all these tools available, all tools in relation to prevention, and there's one specific site that summarizes those that are most important for GC8. Next slide. And here you have an overview, really a map of the different tools available. We have, of course, guidance tools, first columns, planning and management tools. We have analytical tools, so the more quantitative tools. And really one that brings it all together is the first in the upper left corner, the HIV Prevention 2030 New Access Framework, which is based, and you see that on the top in the top right corner, the prevention needs estimation tool. So for the prevention response, those two actually will give you a quantitative but also a programmatic sense. And for key populations, if you just wanted to look at two documents, it's the consolidated guidelines that we already covered, and then it's another document managing and planning and managing HIV programs with key populations that we'll look at in a moment. And then, of course, if you have then specific needs or questions, you can dig deeper with the other guidance documents. But those are essentially the most important ones. Next. Global AIDS strategy, of course, provides the framing, and it will be, translated into a political declaration still this quarter, 22nd of June, high-level meeting. So you have highest level political backing for these targets, including the prevention or the community response targets. Next slide. We then actually have the new prevention access framework, which provides a number of propositions on how to frame prevention, highly prioritized set of people-centered approaches with some people-centered design and communication, so socio-behavioral elements well prioritized, prevention platforms well prioritized, social enablers well prioritized, and then an optimized mix of prevention options, and all based on the context, which is then, if you go to the next slide, can be established through the 5 P's of prioritization. So what the right mix across those 4 dimensions is can be used or can be determined through a prioritization algorithm to determine the right people, places, packages, best platforms, and prices. And the prevention needs estimates and other resource planning tool. There's also a new resource estimation tool for country applications that our colleagues in the economic department have introduced in a recent webinar that can be used for that. Next slide. Now, the prevention framework also provides these tables that can help define quantitative targets for both prevention options, including, of course, condoms, PrEP, and harm reduction, and then the different population, and then the segmentation type of analysis of, what proportion of targets would be achieved through different modalities. Next slide. So the key document here, and I'll not repeat what Maria has already said, is planning and managing programs with key populations. That replaces the older guidance documents on trusted access platforms with that greenish cover. And it basically has 2 parts. The first one is really describing how do we build trusted platforms? How do we build that key element of trust through a programmatic approach? And the second part is then really the practical management guidance on establishing really a systems approach. And what this responds to is, of course, we've had often project approaches by different funders, or we have had key POPs programs focused more on testing and treatment, maybe, and some more focused on prevention. The idea of the trusted access platform is really the systems approach to it. If you go to the next slide, actually, and maybe this is the main visual and prioritization graphic in this document, and it basically responds to how can we look at key population programming with a national and not a project lens. And often we get questions like, oh, how can we sustain the 7 drop-in centers that we may have had through maybe a PEPFAR Global Fund program or another funding source? And this graphic is really an invitation to look at, how can we actually differentiate key population access platforms based on 2 main criteria, depending on how many resources we have available. So we can, of course, have more intensive programs if we have more resources available, and based on HIV incidence, we can actually have more intensive programs where we have higher HIV incidence. And if you look at this, there's some basic foundations, of course, the community engagements, the human rights and legal environment. But then the question is, what can we do with very limited resources? We can probably, within the existing primary health care, with those limitations that Maria highlighted, make those pharmacies, for example, or health facilities, CoP competent through guidelines, directives, training of health workers. But all of that will take time and is not sufficient. So based on, the scalability of resources, you see then what could be done specifically for key populations through other modalities. Peer-led outreach in virtual spaces, for example, could be easily scalable, but will again not reach everyone or be suitable for everyone in that, interim period where we need to assume that health facilities in the primary healthcare, even with adequate training, will not immediately be trusted for everyone. So we need peer-led outreach modalities in physical settings, and then with additional resources. And for those with greatest vulnerability or highest HIV incidence, the more intensive modality as well. And there's something, of course, between, a really dedicated clinic site for key populations and the general health facility with maybe some basic training or guidelines. There could be key population rooms or days or peer navigation that makes existing health services more accessible for key populations. So it's really an invitation to think about how can we differentiate based on need for the different population. Next slide. And I go very fast from here. The SSLN has a number of tools available. There's guidance on young women who sell sex specifically. There's also a similar guide from Asia Pacific on young key population, obviously critical, in particular in considering the access platform needs for young key populations, prevention cascades, and the peer education synthesis evidence report. Next slide. So there's a number of tools available for community-led response. And of course, the design slide that I showed before should be done with communities. And that includes both the community-led design, community, including peer-led service delivery, and community-led monitoring dimensions. And again, using a systems approach, these documents will guide you in what functions of the programs can actually and should be prioritized for community leadership. Next slide. We have guidance available for stigma and discrimination, again with 2 streams. On the left side, guidance and practical tools for broader interventions to reduce HIV-related stigma and discrimination, but then also, and this could inform some of the key efforts to make health facilities and primary healthcare key population competent, ensuring quality healthcare by reducing HIV-related stigma and discrimination in the healthcare dimensions. So that's WHO guidance documents, and you see the other documents from the global partnership here on the left side. Next slide. Overall, we also still have a checklist available for Global Fund GC8 applications for prevention. It has for different sections of the proposal, some key questions in relation to HIV prevention. And then on top, we have just a top 10 checklist for prevention in GC8 requests. So thanks. I'll end here. Perhaps.
Wow. You have 1 minute and a half. Go ahead.
No, so perhaps just to remind everyone to access the resources on the resource hub of the Global Prevention Coalition, and we'll have one more webinar that's specifically dedicated to prioritization. And overall, I think in those prioritization criteria that I mentioned, and perhaps that's one thing to remember, HIV incidence is the key thing that will determine whether HIV prevention is impactful. And key populations have in all settings elevated HIV incidence. So there's a really strong case to continue investing in programs with key populations in GC8. Thanks.
Thank you so much, Clemens. I cannot believe everyone is making it on time, so I'm pretty happy. So thank you again for walking us through these practical tools to help countries make transparent, data-driven choices on what to prioritize, to protect and adapt, and also to integrate for key population programs in GC8. I think one key message that I can take away right now, it's a question you asked, is what can we do with limited resources? So now we want to hear from you, the audience, our participants, to please access the Mentimeter through the QR code and let us know what you think on the following questions. So what information about GC8 would best prepare you to advocate for the inclusion and prioritization of key population programs in the country proposal? So from all you have heard, from your experiences in country, what is there that can actually help you from what was presented? I'll give you all the opportunity to start putting in your thoughts, your observations. Yeah, we have people still responding. It might be a little bit slow, but keep your points coming. So specific examples of integration of key populations activities into HIV services, including cost savings, cost effectiveness of integration. We do have a point on how young KP can be well flagged in the country proposal. Very important for us to maybe take this point into our discussion. Sharing of how other countries were able to navigate the internal politics to get all people at the table. So bringing people to the discussion, making them participate and engage meaningfully. Acceptability of integration services for criminalized populations, very important point here that we need to consider for sure. Not everyone will be feeling confident and have trusted access to services. Again, best practices, tools that come with a level of technical assistance, even if it's discrete technical assistance per day or session. So good consideration for the community of practice to think about this, epi data and modeling. And I will not go into much detail on that because these details were mentioned before, but just if you that are in the session, if you have any specific examples and publications on modeling, please include it in the chat and share with us. Building competencies for key populations in traditional health facilities, very important, the aspect of sensitive services for key populations. How can we confirm services that can be integrated regardless of the legal implications, protecting, therefore, our key populations when they access services? How can we make it work? What are the examples? So these are great suggestions that we are having in terms of what are the examples we have available, and for possible upcoming sharing. So if the SSLN group or GPC has any recommendation on previous sessions or materials that discuss these points on sharing experiences for integration of KP sensitive services, please do direct our participants to that. And lastly, we need to distinguish between services that have successfully done the community-led, by community-led, for us to be where we are. I think this is quite important. What are the successful achievements and what has worked? So I think I will just invite us to jump to our next session. I'm hoping that we will have more info of the responses available for reflection. But this is how, or this is the time where things come alive after we got these presentations from Clemens and Maria. Thank you so much for your contributions. And now we want to welcome country and community experiences to show experiences and lessons learned from the actual contributions and implementation in country. So first, I will welcome Velta Pakromenko, apologies, a feminist activist from Ukraine with lived experience of drug use, who uses her personal story to support and empower other women who use drugs. With a master's in psychology, she chairs the community-led organization Club NA, with over a decade of NGO leadership, advocacy, training, and facilitation. Velta, over to you. You have 5 minutes.
Thank you so much. Hello, everyone. My name is Velta, and my organization, Club NA, it's community-led organization working with people who use drugs with a strong focus on women. And thank you. This discussion is really important, especially in the context of GC8. And from our experience in Ukraine, we have really good experience of meaningful engagement of key populations, and we see it's really important and critical. It directly affects whether programs reflect real needs and actually work. And what works is yearly and structured involvement of community networks from the design stage with access to data and real participations in setting priorities. However, in Ukraine, we face serious challenges in program implementation and design. First, engagement is often, as formal or too late, without real influence on decisions. For example, government can invite 1, 2, 3 experts for some meetings, but not for whole process. And also, we have some systemic barriers, the stigma and criminalization of people who use drugs, and also, of course, war-related disruptions, because we have war situation in Ukraine now and unstable funding approaches. And for now, major issue is how verification systems are implemented in country. According to the consolidated position of NGOs and communities, verification should be a tool for quality, not a condition for payment of these services. And it's really important. And also, it's become especially difficult when implementation rules create risks for programs. And also, it's really difficult when we have dual role of communities. We're expected to both contribute to proposal development and at the same time advocate for advocacy and for quality and accessibility of services for key populations. and it is more difficult and it needs more resources from us, from key populations. And current monitoring approaches raise serious concerns around confidentiality and safety. They can expose sensitive data, for example, increase stigma and risks of criminalization. And also the cost of services or verification requirements must never limit access to services or reduce their quality. And for us as key communities, it's critical, important. So we work to address these challenges through collective advocacy, consolidating the position of NGOs and communities, and insisting on approaches that protect both quality and human rights. How has government ensured key populations engagement? There are formal mechanisms for engagement in Ukraine, and community organizations are invited to participate. But meaningful engagement still depends on timing, access to information, and whether input is actually reflected in decisions. And I think if you say about our experience and maybe some advices to other countries' process, first, I think key populations need to engage early at the priority setting stage and work collectively and build a consolidated position with key populations and government and NGO also, and also insist on access to data and decision-making spaces and advocate not only for inclusion, but also for safe and ethical implementation, because for key populations, for example, for people who use drugs who are criminalized in most of countries, it's really important. I think that monitoring and verification systems must not violate...
1 minute check.
Thank you. Confidentiality must not create risks for communities and must not become a barrier to accessing services. And our meaningful engagement for key populations, it's not about participation. It's about ensuring that programs are safe, effective, and truly responsive to people's needs, to needs of our brothers and sisters in community. Yeah, so that's all that I want to share. Thank you so much.
Thank you so much, Vilta. This is very impactful in terms of realizing how collectively advocacy, can impact our presence in this discussion, especially for communities that are really struggling with getting access to services that are, high quality, free, safe, and stigma-free. Thank you so much for your contribution. You're not going anywhere. We still have our panel discussion, so hang in there. I am now welcoming Dr. Kwado Owusu. He's a public health pharmacist and supply chain expert, head of treatment, care, and at the National AIDS STIs Control Program in Ghana Health Service, with extensive experience in HIV program management, playing a key role in ensuring uninterrupted service and commodity availability in Ghana. So, Dr. Kwado, over to you.
Hi, everyone, and thank you, Clarice, for the rather nice introduction. So, in the next few minutes, I'll be talking about Ghana's experience trying to prioritize KP interventions in Global Fund applications and some of the recommendations based off that experience. Next slide, please. So for countries like Ghana, where there are significant structural challenges, stigma, discrimination, and in some cases, punitive legal environments remain a significant barrier. Limited availability of reliable KP data is also a challenge because most of the time we need reliable data to make the necessary push that we want to. And also the de-link between the evidence and how budgets are allocated also is a challenge for us. Again, limited involvement of community members in various processes. And most of the time, we focus on the dialogue and the proposal development. But from my experience, it starts way before then, at TWG meetings, at midterm reviews of NSPs, end-term review, and development of the NSPs and so on. Because it's these things that largely drive the proposal writing. And of course, the competition. We have so much to do, but so little in terms of resources. So how have we tried to overcome the situation? In terms of data, a lot has been done over the past few years, trying to make more data available. For instance, recently, to support our harm reduction efforts for persons who use drugs, we needed to do site mapping, size estimation, and all that. And once that data is available, then we can use that to make the public health case for some of the things that we want to do. Again, inclusive dialogue. It's important that community members are part of the dialogue, not only present, but are able to make a case, which moves on nicely to the next point of technical assistance. Because many of the times during these proposals, you have various experts, sometimes from outside the country, providing specific support, let's say in treatment, in PSM, in M&E, and so on. And so you may require to have experts who can come in, look at the data, and make a case for some KP interventions. And also capacity building. No matter what support we can provide from the ministry's angle, we need to have the necessary capacity within the community to be able to advocate for various things, and also to knock on doors when necessary, when people are keeping their eyes away from them. And one other thing I'll add is prioritization. Trying to have everything in there sometimes results in having virtually nothing in there. So you look at the data, you prioritize what is likely to sell, and then you go out there and then try and make a case to others. The next slide, please. So with all that, the recommendations I would give in terms of the structural barriers which results in the high stigma, discrimination, and all that, is to first of all have the data, use the data to help make a case for the public health interventions, and then gradually we will be able to improve the situation. KP networks, I've mentioned that the need to build capacity so that they have the necessary knowledge, but are also proactive. Data is extremely important, because at the end of the day, without making a case using the data available, you are not likely to convince anybody. And prioritization, I think I've touched on it. Look at what is most important and then push on with that. Technical support, there's a lot of support actually out there. So as and when we realize that we need to put in a stronger foot, then we can always leverage on expertise from various organizations, even including WHO Global Fund, Initiative, and all that. And then finally, accountability. Very important. Every country wants to improve the fight against HIV. And so whatever resources are being requested for, we need to show how it would improve the country's performance. And many a times people complain about project data or specific community interventions giving out good data, which does not reflect in the country's data. So being able to show how the whole thing is mapped out is very critical in convincing stakeholders to put in the necessary resources. So
1 minute reminder.
Thank you very much, Clarice. You can have that 1 minute.
Perfect. Thank you so much, Dr. Kwadu. This is very good points that you have raised, and thank you for sharing Ghana's experience in navigating prioritization challenges. in Global Fund applications. Also for emphasizing the importance of strong data, including, country dialogues that are continuous and not punctual ones, and sustained engagement with key population partners. This was actually raised in the morning session. A point in the morning session was also crucial, looking at communities also need help to get to this discussion. So very much thankful for having this, discussion in place. Following the Mentimeter questions and points, and also, aligning with who we have in the room. So we have Maria representing the Global Fund with great presentation on the process, Clemens on the tools that are available, Velta, community perspectives and issues that need to be sorted. That also link with some of the points that were raised by Dr. Quado. I want to start by looking at one of the questions that were raised that were quite interesting, and I think we could tackle now, is perhaps to Maria. From the Mentimeter and from Dr. Quado's presentation and some mention from Velta as well, how should countries address the need for technical assistance in their application? Specifically, how should TA be positioned and justified within the proposals? Any thoughts from your side?
Thanks, Clarice. I think it's a great point. We dropped some links in the chat on TA specifically around community TA. Just to note that for window 1 and 2 for that community TA, it's unfortunately too late, but for the further windows, there are still opportunities to apply for technical assistance. I also wanted to highlight the learning hubs, who are regionally based and provide a wealth of information for communities and implementers, and all those actually engage in Global Fund processes and implementation in relation, and they offer learning opportunities and are doing a number of upcoming webinars on different topics that have come up today in this meeting. So I think that's a great space. Others, of course, offer technical assistance such as Expertise France, GIZ Backup, and countries can plan to engage with them. And I think our colleague from Ghana really highlighted well how those opportunities can be leveraged and utilized. And so I hope that covers at least some of it. And we'll continue to drop links in the chat so you can explore further after this webinar in terms of how to access some of those resources, TA and beyond, in terms of learning opportunities. And I'd also really like to highlight the work of course, SSLN and GPC and our technical colleagues from WHO, UNAIDS and others in terms of their efforts to provide the normative guidance. There's a wealth of materials and toolkits now online. I would say we have more than enough in terms of guidance materials, checklists, tools. It's really very impressive, very thorough, and I think it offers really quite a bit in terms of what folks might need to equip them to be able to have those conversations and make the difficult choices, as we've mentioned, and prioritize in country. Maybe I can also come back to one of the other Mentimeter discussions, which was really around integration. Please. Sure. Criminalized populations and how to tackle that question. I think what's important is we were discussing 3 options: optimization, adaptation, and integration as strategies that you could consider using in terms of thinking about how to sustain KP programs for the future. Integrated models can work for key populations if they're done over a period of time, if they're done carefully with community input and consultation, if some of the structural interventions that Clements, I think, spoke to very well at the bottom of that slide in terms of addressing barriers, reducing stigma and discrimination, and ensuring accountability mechanisms for communities are in place. All of this is, of course, possible. Having said that, it may not be the preferred option for communities, in which case we continue to go back to that discussion of where can programs be optimized, how can they be adapted, how can new platforms be leveraged to reach communities such as virtual interventions, CoP competent pharmacies and others? And how can we build on that trusted access platform approach, as we mentioned at the beginning, to ensure that access continues? But a sustainability angle needs to be built in across all of this, which is why those three strategies, I think, are helpful. I dropped another couple of links in the chat with some guidance and examples, and thank you to you, Clarice, as well, for also dropping the other examples into the chat. And I'll leave it there, but I hope that answers some of those questions. Thanks.
Thank you so much, Maria. Very helpful. I will now jump to Velta. I think one of the points we made when we were, looking at your presentation and some of the discussions was specifically on the community engagement and successfully engaged in the process. You spoke a little bit about the challenges and how to think about overcoming them, but what advice do you have for other CLOs, that are joining the process and having difficulties? How can they advocate for being in the room in a continuous and engaged way?
Yeah, thank you for the questions. About advice, I think for us as key populations, it's really important to be strong because sometimes, government, for example, or other players can propose some benefits to have some compromise situation. Yeah, and for us, it's really important to be strong and have our goal to the advocacy, and remember that it's not about my voice, it's about voice of whole my community to have really with simple access to high quality services. It's about all our health and wealth. And it's really important because sometimes in some countries, government can try to shout our mouths with criminalizations and other punishment, So for us, it's really need to be strong and believe in our win. Thank you.
Thank you so much, Velta. I think believing in your strength, holding hands, the more you are and the more you have a strong message together, this can definitely help communities to stay in the room and advocate for that space. So now I'll jump to Dr. Quadro. Perhaps you could, you spoke a little bit about that, about the needs and the data and etc. But how has your government made sure that key populations, community-led organizations were engaged in the process, ensuring that it's not only at the start, and if you had challenges for that, and I think you mentioned a little bit about that, what are the changes that you're putting in place to overcome these challenges?
Thank you. So we've tried as much as possible that throughout the entire process, we involve CLOs and members of the community. So a recent example would be the development of harm reduction guidelines as part of the country's recent start to put in place some interventions. And we have members who are present in the TWG, not just one or two, but a number of them, as well as some organizations. We've also tried to leverage on external experts who could come in, orient the group in terms of some of the ways to look at things as far as the community angle is concerned. So that speaks to the technical working group aspect. When it comes to our NSPs, which drives what we usually do in terms of the proposal writing, we've involved members not only in the development, but in the reviews. So the midterm review, and as we had recently, the end-term review, and the subsequent development to ensure that the necessary interventions or activities are captured in the NSP, so that by the time we get to the grant writing itself, the basis or the foundation would already be set. And so that helps significantly. That said, it's a continuous fight for a country in Ghana that still has a lot of structural barriers. It's a daily fight trying to make a case. But as I said, data is important. Everybody wants to have good public health. So you sometimes look at the data and try to use that to support the justifications that we want to make. Thank you.
Thank you, Dr. Quadro. And there was a point that was raised during the Meta as well related to engaging young people from key populations. There is a recommendation from WHO emphasizing the need to think about services for young key populations, and definitely the entry points for these services could be considered as a link to sexually reproductive health services, and combination of an integration of other important services. But I just wanted to hear a little bit what is the role of young key populations in the process as well?
Yes, and I'm happy to report that we have some rather strong CLOs that have come up over the past few years, which are mainly for young key populations or for young key population-led groups. And I think that their coming up has helped a lot because the voice in the room has become louder, and they are present on our CCM to ensure that at any point in time, it helps. What we've tried to do to support them is to help with one of them in terms of setting up, helping them to have a constitution, working documents. For another one, we provided technical assistance to be able to address some of the things they wanted to do. And for another young key population group last year, we helped them with TA to apply for some funding to help some of the things that they wanted to do. And we feel that these are not side events, but these are critical things for us as a country, because once they are strong, they really support the fight. So I would encourage that in all other countries, if such groups emerge, that the necessary support be provided by governments to strengthen them, because eventually they would help us attain the objectives that we have.
Thank you so much, Dr. Quadro. This is very helpful. Clemens, you're not going to be left alone. Don't feel lonely over there. I have a question for you as well. I think in the morning session, there was, an ask to, how should countries approach selecting and justifying specific tools for their proposal making process without overprescribing tools that may need to be adapted during implementation. Also considering limited time for engaging in this process. So what are some tips that you can give for countries to choosing the right tool for the specific context?
So I guess it will really be contextual based on where the country stands, whether there's already a strong program. But I think overall, what is perhaps most important is a shift in mindset, where in the past we've often thought, we design a project and then in future we scale it up based on the lessons learned and when we have more resources. And we can probably say, at least for international resources, we will not have that most likely. So we now need to think, how can we design a system with what we have available internationally, and maybe we can increase domestic financing. How can we design a system that serves all key populations in need. And then with that, of course, and using the epidemiology, the use of specific tools would follow from that. And of course, probably, of course, the WHO consolidated guidelines for the defining of packages, and then the managing and planning HIV programs with key populations. So that guide we spoke about for the designing the system could be helpful in general across different settings. And then, of course, all the detailed guidance for specific settings. And I didn't speak much about, the guidance for condoms and PrEP, which we covered in other webinars already. But of course, wherever the country sees gaps towards targets, it might be useful to dig into some of the specific guidance products. And of course, maybe because of the resource dimension, of course, we have also had often separate cost structures in our key population projects with quite high unit costs sometimes for certain things. And I think what we'll need to think about in this system design, how can we align this to what could be sustainable country costs that make it easier for national or domestic authorities to cover some services. And I mentioned OAT as an example, but great potential for co-financing. Governments might not be able to co-finance everything, but at least having domestically sustainable cost structures could help that.
Thank you so much, Clemens. I think this is quite helpful in the fact that if we don't have the data, we might not know where to focus and which tools to use. And also knowing where your grants are and where you are in terms of implementation of these services can really help you make better decisions and use of the tools. I wanted to perhaps go back to Maria. And there's this one aspect that is quite that has been discussed, and some wording that perhaps might be helpful for participants to understand is looking at the funding transition plans. Is it something that could be a plus for countries to include when they're discussing key population services and integration? And by that, I mean, some countries are fully, supported and funded, for key population services by external, from the Global Fund, for example. Some are midway with some domestic funding. Some are transitioning as we speak, but they rushed a little bit. So there's a need to put into more money for continuation or improvement of those who have transitioned. But how do you see some kind of transition plan from external to domestic, a specific timeline to be put in place? How do you see that supporting? And do you think if this is an added value for countries to include that in their proposals? Thanks,
Clarice. No, I think it's a really important discussion and one that I think will merit further deep dives. In relation to submitting a transition outline, countries that are core or on an accelerated transition timeline will have to do so as part of the package when they submit their applications to the Global Fund. There isn't a specific template for this, but there is some principles upon which countries should consider. From a key population perspective, what will be really critical is to really clearly highlight how services will be sustained, how it will be acceptable of quality to communities, how access will continue to be maintained, how communities will be engaged in that discussion, how they were engaged with the CCM and beyond. And I think some of our community partners, particularly those in Eastern Europe and Central Asia, have produced a wealth of tools in relation to transition readiness, in relation to community priorities, and I'll drop that in the chat, but a lot on the Eurasian Harm Reduction Association website, which is also a learning hub of the Global Fund, is one such. So I think that's key to kind of outline that some countries will be required to do that already. Beyond that, while that's not a requirement for all countries, I would say, as we've mentioned all the way along, sustainability, integration, and those strategic shifts that I highlighted at the beginning of this, and on the road to self-reliance at the beginning of the presentation, will be a focus across all portfolios. So while you may not be required to submit the transition timeline, the transition plan itself, these kind of key priorities will be part of the conversation, part of the country dialogue, part of the process moving forward. So, and that builds into this transition discussion, I think. So I just wanted to highlight those as well. Thank you, Claire.
Amazing. Thank you so much. I also put in the chat, we still have a couple of minutes. And I'm just thinking about engagement with our audience. I'm still considering that you are also experts. You are here, but you have some knowledge of the process. And for community-led organizations, I just wanted to ask you to please drop in the chat if you have used some of these tools. How can they support meaningful engagement of community participation in writing and implementing, key population services? And for all of us, if you have, used any of the tools that were presented today in the GC cycles, any previous or current cycle, please drop one short tip in the chat. Which tool helped most? How do you choose which tool to use, or what you do differently after having the knowledge about that? So it's just an open question for you to put in the chat, and maybe for others to read on and try to learn from each other. So as we reach, this couple of questions that I covered, I don't see any additional questions in the Q&A, but I did see a relevant comment from Niliswa Intinde. She's saying, beautiful presentation. Slowly we will get there, winning our local facilities to integrate and work well to gain trust from key populations from South Africa. So this is a very good message that I think it's good for all of us to consider as we get into this process, that is not only for the proposal writing, as it was mentioned before, it's also to making sure that we continue to, implement and monitor implementation and adapt as needed, because we cannot do anything that stops through the process. And I would definitely recommend us to think about a quality assurance type of approach. Most countries have their plans for quality assurance overall for, any health system implementation and follow-up. This is going to be crucial as well, because we know that some things are new and we need to be flexible to identify what is working, what is not working, and have touch bases with the community to understand what can be changed and what are the preferences. I don't see any additional questions, but I would like to perhaps go to the next slide. And just, as a way to get your feedback on the key populations community of practice. This is important for the upcoming meetings, for webinars, so that the focus that we have in these sessions are mainly coming from you and important for you. So please complete this short survey. And making sure that you stay connected and for practical and responsive, tools and materials that can help you with the response. I think one of the key points that I would make is if we have anyone in the audience that would like to raise your hand while people are doing their QR codes, and if you want to add anything, make a comment to the panelists, to the to the community of practice, to WHO, please feel free to do that. this is the time. So please feel available to or free to raise your hand, and also to let us know how the session helps you with this upcoming process. So let me just give you 1 minute, and while you're thinking, I would say that for any panelists, any last words, any points that you would like to make, I can open up for 1 minute, last word, last message that you would say, this is what we want you to think about when you go through this process. That is not easy, and it's well acknowledged that it's not easy. Maria, I see your camera, so perhaps I'll go over to you.
Sure. Thanks, Clarice, and thanks everyone for staying on to the end. So good evening or good morning, depending on where you are. In terms of the final thoughts, I think we've covered quite a bit here, but I would say one of the points that I think it would be important to take away is around the alignment of across key population groups and communities in coming into this process. And as I mentioned at the beginning, being very clear on those priorities, speaking from the same place, and really reinforcing each other's priorities across communities. That will really be a strong way to come into the process, and I think we've seen from our other colleagues who have spoken today that's been a successful strategy. So that would be my main takeaway today for the group. And thanks very much for the opportunity.
Thank you so much, Maria. Thank you so much. And can I just jump to Velta as well? One last message for communities and governments and key stakeholders that are in this call.
I think we need really to trust key communities, because our motivation to work, it's not about money or health of whole society. It's about our lives and our own health. So just trust us, ask us, invite us, involve us, and be flexible with us, because we really know how we need to create these programs to be most effective for us. Thank you.
Thank you so much, Velta. Thank you for joining us. Dr. Quado.
Thank you. So I'll say for countries.
Sorry, you went muted, Dr. Quado. You have to unmute.
Sorry. Yeah, so
Go
for
ahead.
countries like Ghana, where there's still significant structural challenges, I would say the name of the game is evidence. And it's all about getting data, understanding the data, and using data to support what we want to do. And that goes to both government and CLOs as well. Thank you.
Thank you so much, Dr. Quado. Clemens, last word for today's session. You might be muted, Clemens.
Maybe a last reflection, and maybe a provocative one. I mean, often if we've looked at programs in the past, almost 80% of it was above site sort of conceptual, and 20% high quality maybe, and 20% maybe really decentralized deliveries with the communities. And maybe we need to turn this around, that the decentralized services and the communities should really be the focus of the systems we design, with, of course, good quality assurance and strong support, but really decentralizing and designing a system that works for all key populations that need services is the prerogative now.
Thank you so much, Clemens. Thank you, panel, for your contributions. Just to go with a few closing remarks from my side. Next slide, please. We are all together in this struggle, governments, communities, implementers, partners, and we will get further by learning from each other through these specific platforms, by sharing and by planning as a community. We are all going for the same objective and target, which is improving health. Thank you again for having the time, to join us. Next, and before we close, just to remind you about the additional resources, and information that will be available very soon, I think in a week time, for the recordings for the session and slides, but also to remind you that earlier today, we heard from country examples from Indonesia, from Inti Muda, Kenya, NASCOP, and ASWA. And you can access that as well through this platform. So thank you very much and have a good rest of the day for you all.